Okay, so would anybody like to ask the first questions? We have a question.
Thank you. Looking at your experiences with the teleconferencing part, I noticed that the Finnish pilot had far the most usage and the best experiences. So, first and foremost, Dr. Rindala and also the others, why do you think that is? So is it just the level of technology you chose, the prior experience, IT support, or something else? Sorry.
I didn't hear properly what was your question. I mean, our experience. You thought that we had the most experience.
Sorry, you had the best experience. So you had a lot of sessions, and your users were very happy with the sessions and with the results of the sessions. In the other countries, very few sessions, and the users were not so happy.
Okay, I don't start to argue with you, but I didn't see that we had the best experience. But yes, we did a kind of questionnaires and then focus group interviews. And of course, focus group interview is a kind of qualitative study. And in that study, all those positive aspects came up. I cannot really say anymore, but I do believe that the others had similar experiences when we have been discussing, so I cannot really say that our experience was unique, but thank you that you appreciated our pilot so much.
If I add to that, I do think that this Finnish pilot was good. I think it was because they had if I was to comment on that, I think they had an intense tech interest, and also I think had some built-up knowledge from the beginning. They knew what they wanted. So I think when they started working, I think they knew exactly what pilot they wanted to test. So that was good. But then again, I think we're down to comparing apples and pears. I think the pilots have different context. If I'm looking at, for example, the Swedish pilot with wound care, I think there were fewer assessments. So, I mean, we have to compare what is quantified and what is the qualitative statements. So I think in general, it's really hard to discuss success factors and just have the quantitative numbers because they are very different situations. But I think this is also coming down to the final reporting, is trying to level out and compare, although you have different cases with different factors, try to compare them in terms of, for example, satisfaction and efficiency.
Тобиас, я хочу тебе задать вопрос. Спасибо за великолепную презентацию, которую подготовила Эви. У вас большой опыт по телеконсультированию.
Tobias, we would like to thank you for your presentation and the teleconsultations that were done with the help of Evi's pilot. It was excellent.
Одной из проблем, которую ты озвучил, которая следует за внедрением этих технологий, является техническая поддержка телеконсультаций. Если можно, в двух словах скажи, как вы этого достигаете, вы давно работаете по этим технологиям, что у вас получается в итоге?
One of the main advantages is your technical support, and you have achieved quite good results in technical support of the project. So what were the steps how you achieved these results?
I assume that, of course, you mean in terms of the pilot, and I think part of that, I think if we're looking at the Swedish situation, has to be that even if I'm complaining a lot on the IT facilitation and infrastructure control we have, it is actually good and it's been working for a long time. So I think that's one of the factors. There is a kind of technology maturity. So we have to say thank you to that, while it is also a kind of a stopping point also, because when you have something which is mature, nobody wants to change it.
I would like to ask you, how did you manage the consultations time, and what do you think, how it should be done in a real work?
I'm not sure I understand the question, but if I look at this, if I take, for example, this wound care pilot, it was done in reality. So this was deployed in real situations with real nurses, real doctors, and real patients. So at least, so it was nothing fictive about that. The fictive thing was that because of IT, we basically broke some protocols and running sessions on the side besides the original IT systems. But it was done live with real patients and real doctors.
Our situation was a little bit different. We had a kind of forum for teleconsultation. So it had a topic, and there was discussion about patient cases which doctors were able to present. And of course, this type of conference or session, we just put up the time. So it is from 9 to 10, and that's how it is. If we want to have a consultation, ad hoc consultation or acute consultation with the doctor from home, of course, that is a little bit difficult to agree if the doctor has full schedule. So there should be a specific person, specific doctor to be available for consultations. We had a small test with home patients, and their doctor was available for the time when the consultations were going on.
I don't ask nothing, but I belong to the same organization and like Raimo, and I must say that in Kauhava primary healthcare results depends very much that Raimo has been a big motivator in our organization. I think that's why the results are so good.
I buy a cognac for you in the evening.
I would like to give a question to Professor Larsson, because he first mentioned legal problems. Some patients get improper treatment or even damage to their health. In that case, when a mistake is made by the consultant, the doctor of the hospital, who is responsible for insurance company or to the law, to the lawyers, if the patient gets mistreatment?
That's a spot-on question, one of the biggest ones. In general, I would say that the same procedures are in place as it is today. So as you look at it, for example, if you have someone responsible for the patient, it doesn't really matter how many people you ask, whatever you do, you are still the responsible person. So even if you take advice from somewhere else, it's still down to the doctor who has the responsibility for the patient. But this is something which, of course, people have to look at in the future. Because if we are going to deploy these systems, this is going to be a huge discussion in the future, especially if we go to whether written documentation, written transcriptions, whatever it is, whether they are right or wrong. But today it's the same as it's always been, it's the doctor.
The same in Finland. Even you ask advice and you use the guidelines, you are responsible for your decisions.
Okay, I have a question concerning data security. Mr. Snowden revealed certain documents that shocked the world. And how has this influenced the e-health community? And has there already been increased demand for data security? And what do you think? How will the patients behave and the healthcare professionals in the future? Are they going to be more worried about what data is being shared and to whom? Who's reading the data that's saved?
I mean, that's a very open-ended question because it hits a lot of actors. I think First, we're going to see a change in the future where I think the patient, we as persons, are going to own our own data. This is going to be challenged all the way until we actually have that decision. But today, I think this is why, I mean, again, I'm complaining on my IT departments, but again, they're doing a good job because they don't want to release a lot of data before they know what is actually happening. So this is what we see. If you start working with video and audio, you need encryption of that. And when you have it stored on hard drives, etc., how do you make sure that you have the data security? But on the other hand, we can also ask the same question, go back to our paperwork we have today. We have paperwork in file cabinets. How do we make sure people are not reading that? Whatever we do with data, we can actually track, but you don't have control of how many people have actually read a physical file. So at the same time, we have to think about that the systems of today are not 100% secure. So whatever system we're moving into is better, but at the same time, we have to look into ethics and data security, which I think most people are doing at the same time.
And I do believe that every country has auditing system, and for instance in Finland, before we can have that electronic patient record, it is auditing and our security systems are audited, and twice a year we are auditing, for instance, some important persons who has been looking their data, if there are cases which are not related to healthcare, and for instance, they are looking whom I have been, whose papers I have been visiting, and making sure that I am not visiting without any reason patients' data.
Thank you. I will go to the more soft issues from the hardware issues to motivation. You have all presented that motivation within staff is a crucial factor for further implementation. And I wonder, I know that you don't have any figures or facts, but what are your thoughts? Have you any ideas on how to counteract this and how to enhance them or increase the motivation? Thank you.
Hello. Oh, okay, working. In general, motivation is a really important factor for the participating in every activities, and probably we are here in this conference because we are motivated to listen to the presentations. So participation in telementoring or teleconsultation, motivation of participation is also important. And of course, motivation can be increased by political decisions. If we make a system that people are will be by the decisions involved in activities, or also it can be motivated by the financial issues, also by having infrastructure, by having every what they need to implement activities. And if this will be in daily routine, so this motivation comes not so much important when now we had the implementation of pilots. So piloting is, of course, motivation is more important. But if this practice become routine, probably we will do it as it is our daily practice. So then probably motivation will be less important.
I can see the same way, like you do. When you from down to up, then when you have a good project leader like Raimo, then it's already something. Then you're going up, that you have a management support at one organization, which was also issue before, that in one organization things are moving faster, the data seems secure. But when you start to work with different organizations, you have to have a political support and infrastructure. So I think this is what also Kedrius wanted to say.
I would like to add that motivation means that I want to gain something. I'm envy to somebody who is better than me, and I want to be better than he or her. And the gaining something can be material or immaterial, and in our case it's very often immaterial. It's empowerment of staff to use their skills and knowledge, and I think that it goes further. It's empowerment of the patient as well, and maybe in the future empowerment of the patient and their demand for ICT information and their own data is the driving force. We have to face those needs.
In the morning we discussed about education, and in our former Interreg project, ICT for Health project, one work package was how to develop e-health education. And we made a survey in Baltic regions states also, and we noticed that we have a lot of e-health education for healthcare professionals, but we should develop the content of education. So we should have multi-professional education for healthcare professionals. And one result was also European e-health master program for healthcare professionals. But now I would like to ask you, after piloting tele-consultation, tele-mentoring, how do you see need for education, e-health education, basic education and further education for healthcare professionals, medical doctors and nurses and other professionals? Thank you.
Well, I can see that would work on a couple of levels. First of all, we shouldn't over-mystify a lot of things. I think what we see already today, we see this in Blekinge in our education. I mean, when we educate the nurses, they are being taught entrepreneurship, some aspects of technology. This was previously very unusual to be seen, but we see it today because you constantly have to reinvent your workplace. So we want the nurses to be innovative. We want them to adapt to new scenarios. So on one level, I think it's small changes in existing education. So that's one part of the answer. The second part is that we're going to see a whole new profession coming in, which is health tech workers that is coming into hospitals. So which are basically there to find the needs, develop solutions, software, technology, etc., put them in place and make sure they are working. And these persons basically have to have some clue about health as such, but also be, in general, very good in technology. And these are areas where we see education is popping up. You can call it applied health technology or whatever. So I think it's both educating or putting more pressure on the health workers and also educating a new breed of workers, I think.
Also, what we have after implementation of telementoring programs, we understood that in each country that participated in pilots, professional education already is regulated. But only what we did new, this is we used for professional training and education IT technologies. So very important thing is after implemented pilots that those programs that we have implemented and our professionals has participated in education, that this education that was provided would be accepted by the credit systems or by the regulating agencies, that it could be certified somehow, and that these people would feel that they also this system working not only beside regular system, that they also need to gain additional credits after telementoring or training on IT. So this is same legal questions that is still not solved in all countries, and probably if this would be also legally regulated, it would be also more attractive to participate in telementoring programs.
when we learn more about ICT and learn to use it, I feel that we all the time find new possibilities how to use it. But related to education, I do feel that we should remember that old methods in education, we cannot just transfer them into ICT. We must comply with the new strategies like adult learning methods and lifelong learning methods, multi-professional methods and so on. Yes, for sure, it has a very important role, but as well I am very much promoting that at local level we should be able to empower the local skills and knowledge in use of learning, not only from up down, because adult people, persons, professionals who have been working 30, 40 years in a profession, they have plenty of skills and knowledge which they can use if there is just a possibility for that.
Okay, thank you very much. I'm sure there would be many more questions, but unfortunately that's all we have time for. Thank you very much to our session 4 speakers for their contributions today.